Hello and welcome to eviCore Healthcare's educational webinar series. My name is Bill Cornelius and I'm the Insights webinar host today. eviCore is a company that empowers the improvement of care by connecting patients, providers, and health plans with intelligent, evidence-based solutions to enable better outcomes. If you would like to learn more about eviCore and how we enable better outcomes for patients, providers, and health plans, please reach out to sales@evicore.com for more information. Throughout 2021, eviCore hosts free educational webinars that include guest speakers, as well as eviCore subject matter experts to discuss today's most pressing healthcare topics. Stay tuned for our future webinars with new topics presented each month. Now it is my privilege to introduce you to a panel today. Serving as our event facilitator, eviCore's Vice President and General Manager of Musculoskeletal Business Unit, David Baird, and our clinical panelist, Dr. Robert Westergan, Chief of Musculoskeletal Programs at eviCore, Elise Latawiec, Physical Therapist and Lead Practice Management Specialist at APTA in the Public Affairs Unit, Kelly Sanders, Board Certified Clinical Specialist in Orthopedic Physical Therapy, and Dr. Vycki Rupakus, Senior Product Advisor for Musculoskeletal Solutions at eviCore. This presentation will be recorded and will be available on demand located on the Insights page at evicore.com. Take it away, David.
Thanks, Bill. I'm excited to be here. I'm excited to be here with these panelists and excited to have so many people sign up to join us. This is obviously a very motivating topic. 1 in every 2 Americans will suffer from musculoskeletal disease. I myself, like most, suffer from lower back pain and other ailments. And people take all sorts of approaches to dealing with it, from surgery to ignoring it to opioids, etc. And it's a personal passion of mine to help people find the right solution that gets them better and gets them better quickly with as few side effects and complications as possible. So I believe strongly in physical therapy, and we're happy to celebrate National Physical Therapy Month and invite some of these panelists to come in and talk about that. So before we get started, I would like Elise, Kelly, Vycki, and Bob to speak a little bit about what brought them into this area of care and why they're so passionate about physical therapy and musculoskeletal care. So I'll throw it over to Elise first. Tell us a little bit about why you're in this field.
Thanks, David. I had a cousin that was younger than myself, a couple of years back from me, that was diagnosed with many orthopedic issues early in her teens. And after many years of surgeries, casting, and rehab, she was able to resume normal activities. And really during that period, I worked with her a lot at home on our home program and also went to many of the PT visits. And watching how she recovered and the close relationship that she developed with that therapist really inspired me to consider PT as my future vocation.
Great, that's interesting. Kelly, how about you?
Sure, thank you for having me. I don't have as quite inspiring as a story, but I, in college, was pre-med and had the opportunity to volunteer in student health in the athletic department. And through that time, met a physical therapist, got to see his work and how much time he got to spend with his patients over multiple weeks and really watch them return to function. And I just thought that was a fantastic opportunity to get to make an impact on people. So here I am, a physical therapist.
That's great. I'm sure you have a 1,000 healing stories since then, so that's exciting. Vycki, how about you?
My story is very similar to Kelly's. I had considered a career in medicine since I was a young child. Thought I'd be a physician, but learned about physical therapy at a career day, and really felt that that was a better path for me. And I've really enjoyed over the years working very closely with patients. Day in and day out, helping them return to their prior functional status. So I think it was the right career choice for me.
Great, working with you. I obviously think it is too. Bob, you're sort of on the other side of this, on the surgery side, but I know you're a big proponent of physical therapy and the conservative care. Tell us a little about your journey in this space.
Sure. Well, thank you for everyone joining today on this webinar. I am an orthopedic surgeon and I'm fellowship trained in adult reconstructive surgery. And my journey began back when I was in high school. I went ahead and volunteered in an emergency department in a hospital system. And in the emergency room, I had the opportunity for seeing patients with chronic disease and acute conditions. And immediately I was impacted by the ability to help patients deal with their suffering and discomfort for their acute musculoskeletal conditions versus dealing with their chronic diseases that didn't have that immediate gratification of reduction of a fracture or deformity that I was able to witness when I was in the emergency room. So because of that, I chose orthopedic surgery, which has a good balance between treating patients with surgical procedures and cognitive, uh, cognitive exercise to help patients navigate their journey from their painful musculoskeletal condition without requiring surgery. And we all know that surgery has a lot more attendant risks and complications potential than non-surgical approaches. So the opportunities in orthopedic surgeon, for those who don't know, in most of orthopedic surgeons have 50% of their time spent in cognitive activities or taking care of patients in the office, and about 50% were in the operating room. Unlike some other surgical specialties, that the balance is more in the operating room. So we're very cognitive in our approaches to taking care of patients, and like everyone, trying to do the best thing for them.
Well, that's interesting, and I'm going to ask you to talk a little more about that and discuss with your physical therapy peers about that. But do want to remind everyone throughout this, I'll be monitoring the Q&A. So if you have a question, please go ahead and type it in the Q&A, and I'll make sure we introduce to our panelists so we can make this as interactive as possible. But right now, we'll sort of start off with talking a little bit more about the importance of conservative care in treatment today.
So as an extension of what I just shared, that being that patients, most patients can benefit from physical therapy in their journey of to get to an optimized outcome for them. Physical therapy is one of different approaches for conservative care, along with chiropractic care and other treatments. But there's significant value and I'll get to that later in the discussion about surgical avoidance that's associated with implementing a physical therapy approach to caring for patients. And surgical avoidance is obviously extremely important. So I think when we, back in my background, back when I first started practicing for those therapists on the call, we used to write out a prescription for physical therapy 2 to 3 times a week times 6 weeks. I could have had a stamp that just did that. And then we evolved to evaluate and treat. And physical therapists on the call also know that's how we transition. So at that point, when we made that transition, it was a transformation acknowledging the professionalism and the education and the training of physical therapists. And just as a sidebar, for those who don't know, most of the physical therapy training programs are now doctorate level. So their training and education has really advanced from the time that I began my clinical practice, and their value in the care of a patient's journey is so important now than what it was 20 or 30 years ago. So as you can tell, I'm a real advocate for physical therapy as far as their role in managing these painful musculoskeletal conditions.
So at this point, I was going to talk a little bit about what we're doing at APTA and what we've seen over the course of the past over a decade. And really, there's a large bank of evidence that has really shown early evidence-based conservative care is key to effectively managing these musculoskeletal conditions we're talking about and actually lowering the total cost of care. Beyond that cost savings, the outcomes are much better, which is a win for healthcare plans as well as employers, and obviously the patient first. The APTA private practice section has actually even commissioned an actuarial group, Milliman, to look at this problem specifically around the idea of low back pain, and really looked at the claims, so more of a non-clinical approach. And there's strong evidence, even in that realm, that a PT first approach for musculoskeletal management has some really key wins. Dr. Westergan just talked about the reduction of the need for surgery, which we've seen in these studies. Obviously, we've also seen a decrease in opioid and prescription medication use or orders. We've seen fewer spinal injections. And then one of the big ones, which is actually in like the top 5 lowest valued care interventions is the reduction in radiology, specifically MRIs. And most importantly, again, this has led to that better patient outcome in terms of quality of life, increased productivity, and fewer lost work days. There were three key things that the Milliman Actuarial Group actually defined for us at APTA, and I think they're key takeaways to bring up now. The first one is that if a physician chooses to refer a patient to a physical therapist, like Dr. Westergan just outlined, referrals sent early, and that's in the first 14 days, will definitely result in a lower cost of care and less invasive interventions. So earlier is best. The second key takeaway was that accessing physical therapy, specifically for low back pain, via a direct access route, which Elise will talk about a little later, was the lowest cost method of care and resulted in the very lowest level of invasive care prescriptions or orders. And then finally, some things we're really working on as physical therapists is that it showed that active care is best. So less passive care and more active-based intervention around the ideas of therapeutic exercise and activity, manual therapy, and less dependence on modalities or passive interventions. So with that, I'm going to turn it over to Elise, and she's going to talk a little bit about the efforts we're making at APTA around value-based care and the data collection point.
Thanks, Kelly. Hi, everyone. I just wanted to share that value-based MSK care is really the future, and APTA recognizes that. And we continue to prepare therapists for that shift away from what we know now as fee-for-service payment. So measurably demonstrating value requires that we have outcomes data collection and integration of that data into practice. So not just the data collection in itself, but how does that improve patient outcomes? So while many providers already collect outcomes data and they use it to improve patient care, APTA continues to educate on the importance of quantifying the value of PT. And APTA, to that end, has established an outcomes registry, which is going to serve in the future as the data repository for the profession. And that data will be used to guide PTs in reducing variation in practice and promote value-based services that best meet the needs of the patient. The ongoing assessment of real-time data, and not just looking at past data, will allow us to assess the impact of varied payment models and timely access to care that Kelly just mentioned, whether it's delayed care or timely care, and the correlation to outcomes. This data will hopefully further substantiate the repeat findings that we're seeing currently in research studies that demonstrate that early access to PT and other conservative management results in better outcomes and lower cost.
And then the final thing we wanted to touch on here was opioid prescription and opioid addiction. And we touched on that earlier, that this early intervention with conservative care is helping to decrease that. But when we look at that issue, the numbers are overwhelming. Just when we look at non-fatal costs in 2013, that was $58 billion. And when we talk about non-fatal costs, it's the cost of healthcare and substance abuse treatment programs, but it's also the increase in criminal justice costs and the reduction in productivity. That dollar amount, when they divided that among the 1.9 million individuals that were prescription opioid, that were addicted because of prescription opioid disorders, they found that was about $30,000 per individual, which is an overwhelming amount of money. And obviously, we're not even talking about the lives that ruined. We can think about it in more general terms and just think that as many as 1 in 4 patients receiving long-term opioid therapy from their primary care setting struggles with opioid addiction. So obviously, we're all aware of what a large problem that is. But really, we want to talk about what can we do to change that, or what are we doing to change that as a medical community? In terms of early opioid use, we've seen that patients who saw a PT first had an 85% decrease in the odds of receiving an opioid prescription in the first 30 days of that visit. So overwhelmingly, a huge decrease in that risk. And I share this information because this became very personal to me 8 to 9 years ago. I was one of the people that thought this is a distant problem. This isn't something that affects me or that I'm going to see in my practice. And I'm here to tell you that that's not true. I live in a small rural town of about 20,000 people in California, and I was working in the clinic in that town. And I saw a 48-year-old male about 8 or 9 years ago. He was 5 weeks status post cervical fusion. And he went on to tell me And I wish I could describe the look of shame in his eyes as he conveyed this story to me, that he was addicted to opioids. And he told me about how that happened. Due to this addiction, he lost his job at a nuclear power plant, and he was proud to show me the belt buckle he was wearing for 20 years of service to this job, which was now gone. He had lost his family. Fortunately, 2 years later, he somehow got to an orthopedic surgeon that got him on a better route, who referred him to a methadone clinic, started evaluating the original injury. Ultimately, he had surgery, and the surgeon was really effective in intervening and told him about physical therapy and that this was going to help his road to recovery, and was really helpful to him in getting on the right path. But that has forever changed my outlook on what we do as physical therapists and conservative care providers. I used to say, guys, we're not doing brain surgery. Let's keep it light. I don't feel that way anymore. If we fail a person in conservative care, I feel like we need to be very, very appropriate and diligent and following up with their physician and getting them to that next level of care, because it literally, in this man's eloquent description of what he's been through, he showed me how much it changed his life. We're also seeing improvements that physical therapy is also helping in the treatment of addiction. I just want to make sure I say that too. Methadone and Suboxone aren't the only long-term things anymore. We're seeing physical therapists with the oversight of a physician and behavioral management actually help manage pain in this post-addiction, and helping people if they decide to taper off those things and manage their pain more effectively. So lots of exciting changes that are coming, and just grateful for the opportunity to talk about it today.
Yeah, I just wanted to add about the opiates is that orthopedic surgeons, unfortunately, are tagged with prescribing opiates to a greater degree than other physicians. So as an orthopedic surgeon, our organizations are trying to make a big impact on decreasing opiate prescribing when it's inappropriate. But it's also important to note that the publications coming out in journals have demonstrated that patients who are opiate naive prior to spine surgery, total joint surgery, you name it, have better patient-reported outcomes and functional outcomes than those patients who are not opiate naive going into these elective surgical procedures. So again, just want to emphasize the importance of opioid avoidance in optimizing patient outcomes.
That's great, Bob. And I hope that you guys can hear me. I'm just having a little bit of video problems on my side, but I did want to follow up with you, Bob, on that. As a surgeon, you see people at the front end. We've talked about the fact that that leads them down the path that sometimes leads to opioids and other complications. And Elise mentioned, or I think it was Kelly who mentioned, the impact of physical therapy and radiology and PT first. Can you talk a little bit more about what we've seen at eviCore in our own studies of that phenomenon and radiology versus PT first in a patient's journey?
Certainly. eviCore published a white paper that's going to be updated at the end of November. But the white paper was based on 7 million patients and their medical claims. It was blinded, of course, to the payer. And the 488,000 of those patients had an anchor event of lower back pain within the prior 6 months. So 484,000 patients had an anchor event. And what we looked at going forward for a year, we looked at what services that those patients had during that subsequent 12 months of care, including everything from surgery to advanced imaging to opiates to therapy, to everything. So what our hypothesis was that a PT or chiro first approach would result in those patients presenting with lower back pain would not receive the same amount of spine surgery subsequently than those patients who had other interventions first. So what we learned from the basis of that study is that patients who had advanced imaging first on their journey managing their lower back pain had a 3.5 times higher incidence of undergoing spinal surgery within the subsequent 12 months. 3.5 times higher with advanced imaging. So speaking about advanced imaging for a minute, what happens if all of us may have anecdotal experience about what a report of an advanced imaging study includes. That advanced imaging study report, which is often in the hands of a patient even before the physician who prescribed it, has words like stenosis and narrowing and herniation and severe arthritis and encroachment and all those awful terms that are terrifying and could result in catastrophic thinking. And in addition, those findings, the MRI may identify incidental findings of no clinical significance whatsoever, but patients don't know what's material and what's incidental. So appropriate delay in obtaining advanced imaging is important to avoid chasing down those incidental findings and to help avoid those findings on studies that patients can interpret as serious or catastrophic. So the other part of the study we identified is that those patients who had advanced imaging first had their cost of care was $10,688, so about $10,000 if you had advanced imaging first. If you had PT or chiro care first, the cost was about half, at about $5,000. So I just wanted to share the outcome of that white paper that we're very proud of, and we will be updating it with more up-to-date claims data, but we expect the outcome and the hypothesis that we made to still be true. Thank you, David.
And in follow-up, I have a great story that illustrates exactly what Dr. Westergan just said. And this is just a patient I saw within the last month. She, 60-ish-year-old female, came in. She'd been doing great in physical therapy, had low back pain with radicular pain into her leg. And 3 weeks into therapy, she had minimal symptoms that were remaining in her low back area, but doing very well, returned to nearly full function. We probably had a week or two to go to wrap up her care. And she came in to me last appointment of the day with her MRI report on her phone that she had not had the opportunity to review with her physician. She wasn't going to see the physician for another couple weeks. But in the interim, her physician had referred her to therapy and said, I'm going to order this MRI. I'm really grateful she came to PT that day and brought the report because she was ready to cancel all of her appointments and go back to the physician and say, I need surgery. And she came in that day telling me that all of the words that Dr. Westergan just said, she went over all of them with me and said, look, it says this, I do need surgery. And we sort of had this, we didn't even really do that much treatment that day. We spent most of it talking about the MRI findings and that even I'm asymptomatic, but knowing the results of many MRI studies, 20 to 75% of people that are asymptomatic may have an MRI that will show positive findings and some of those words that Dr. Westergan just said. But it just happens over and over. I can't tell you how often that happens, that it really changes the patient's expectation of care. And she was going to discontinue even though she was almost better because she thought she had this anatomical fault that had to be fixed regardless of how she was feeling and her symptoms. So I just think that's such an important point and white paper for people to read because we see it day in and day out in physical therapy that they want to treat, the patient feels like they need to treat the MRI versus
Agreed.
the way they're presenting.
Yeah, two comments for those who aren't familiar with Choosing Wisely. Choosing Wisely is a representation of multiple specialties that look at evidence-based care. And Choosing Wisely advocates for a delay of 6 weeks, unless, of course, there's red flags that imaging of the lower back is important before that time, red flags that could represent serious conditions. But in the absence of those, the evidence all supports that a delay of 6 weeks of imaging would not be impactful. And the beautiful thing about that is that most patients with nonspecific lower back pain and even with herniated disc can return to function within that 6-week time frame. So the imaging wouldn't even be necessary. So that's an important call out to make.
Absolutely.
The other thing is that I wanted to share is that when patients get a report of their MRI, unfortunately, the first thing they do is start Googling the terminology. And again, that just adds to their catastrophic thinking. What Kelly said is that they think that whatever is on their MRI needs to be fixed. And that's not the case. Most of that is age related. Patients over the age of 40 will likely have a protrusion of a disc at one or more levels, which again is not necessarily the cause of their symptoms.
So Bob, let me interrupt here really quickly because we have a question right about that. So we have a question about the idea of a baseline MRI, not something to advocate for surgery, but just to see what's there and to help prescribe the most appropriate therapy. Do you think there's a place for what we call the baseline MRI, or is that not an appropriate use of imaging and for treating this kind of condition?
The evidence does not support the idea of a baseline MRI in patients presenting the way I just described. Now, if they have a red flag, which means that they're losing strength in their extremities quickly, or they're losing bowel bladder control, or they have a history of cancer, there are red flags that would indicate that more urgent or emergent imaging is required. But there's no real value in a baseline because what I mentioned, if you're over a certain age, you're going to have abnormal findings in your MRI, even if you're asymptomatic. So interpreting that baseline MRI doesn't really have any value, and nor is it evidence-based as an approach.
Thank you for that, and thank you for that question. Please continue to ask your questions as you think of them, and I'll throw them in. Kelly, I think I interrupted you as you were about to go to something there.
No, not at all. I was just going to turn it over to Elise. I think she was going to talk a little bit about direct access and the efforts APTA is making in that area.
Thanks, Kelly. So why is direct access so important, and what does it mean in the context of PT? After a 20-year advocacy effort involving APTA National and its state chapters, we are pleased to report that every state, the District of Columbia, as well as the U.S. Virgin Islands, all have lifted all or some of the referral requirements or order provisions for physical therapy treatment and evaluation. What this means is that now a patient can come into PT and the therapist can treat without having a physician order or other referral source order. This helps to expedite care. It's also in accordance with state law. So keep in mind it is now legal to do that. In terms of benefit design, many plans offer a $20 copay for a month's supply of meds, while PT is often pegged at the specialty copay level and can be upwards of $50 a visit. Given a choice, a patient in this situation that has limited means may not have the option but to seek the less costly short-term alternative. So we have to look at facilitating conservative management up front that will require benefit designers to incorporate lower copays and also immediate access to physical therapy. I'd like to share a case in point that illustrates the importance of data-driven benefit design and really goes to the earlier conversation that was shared by Dr. Westergan. APTA did a multi-year collaboration with a national payer to assess the impact of direct and early access to conservative management, including PT, on total cost of care and opioid use for new cases of low back pain. Based on the first phase study results, the payer introduced a pilot that included no cost sharing for the initial three PT visits, so it would remove that upfront barrier, easier scheduling, and also educated the physicians on the benefit of early PT for low back pain management. The pilot results were so compelling and the cost savings so significant that they expanded the program nationwide. Kelly, I'll turn it back to you.
And I was just going to share one last story about the importance of direct access, but also that patients understand and primary care that PTs can be that direct access first course of care for conservative management. And this one's about my grandmother and my own family, who very much knows I'm a physical therapist, but she called me 2 weeks ago because she had a rotary cuff problem. And she went to her primary care doctor who she had pain for 10 days. She's 93 years old in her shoulder. And she got referred for an x-ray, MRI, and an orthopedic surgery consult. No therapy, no chiropractic, no conservative care. And even in that environment where her granddaughter is a physical therapist, that's happening. So it just really underscored the importance to me of the need to really change these conservative care pathways, because it was an hour conversation with my grandmother to reset her expectations and make sure she understood that, at 93, if we go to the end of this care path that you've just explained to me from your primary care doctor, are you ready to have rotator cuff repair? If that is the case, and you've only had pain for 10 days, do you think maybe we should try a few other things? Maybe even just some Tylenol and gentle movement, even not physical therapy. And so it was just sort of a big wake-up call for me that in my own family this is happening, and what sometimes we will put the patient through when there may be a very conservative course that can help them. Here we are 2 weeks later, she has no pain. I had to bring her to my friend, the orthopedic surgeon, just so that she could really understand that I did know what I was talking about, and she's fine. But we still needed to go through that just because that's the expectation that's been given to her. And again, also underscored as providers that we have this responsibility to talk about all of the options that might be available to a patient. So that I thought was a really, unfortunately, obvious case that happened within my own family about what we're talking about.
I love your stories, Kelly. Elise, we do have a question for you to come in before we go to the next topic. Going back to something you said about the lack of need to get orders in all 50 states. Someone who's practicing in Nebraska said they still receive orders, especially for Medicaid programs. Is that not required? Are they just receiving them because that's the habit of the caregivers to give those in Nebraska, or is it still required in Nebraska?
It depends on the state. The states have lifted some of the requirements, but they're not the same requirements in all states. So there's allowed for evaluation and for the first visit. However, some of the requirements in different states may vary. So some states still have some requirements for a certain number of days the therapist can see the patient without a referral, or a certain number of visits. And to also mention that some of the federal programs and the state programs, such as Medicaid, may have certain requirements that have to be met. And those will vary state by state, particularly with Medicaid.
Okay. And we have another question on that. But Bob, I'll ask you, maybe take the lead on answering this one. Is there a difference in direct access in the context of conservative preliminary non-surgical care versus postoperative care and the duration of that treatment? Now, are you still writing orders for postoperative care, or is that direct access as well?
Customarily, we would work with the therapist to prescribe postoperative care, but not in a very prescriptive way. As I mentioned, the therapists are extremely well educated and trained professionals, and they know what to do with patients postoperatively. You don't really have to be that prescriptive, but again, you would want to have that collaboration with the therapist for your post-op patients, which is kind of the routine. That hasn't really changed much. You would normally prescribe physical therapy after most major reconstructive surgeries. And the other benefit of that is that as a surgeon, I might see the patient, 10 days post-operatively, and then 6 weeks post-operatively, and 3 months post-operatively. Well, the therapist sees that patient on a more regular basis. And when I worked closely to a physical therapy location, the therapist will often call me up or bring the patient over, and we'll take a look at the patient together, check out their wound, make sure that everything is going as required for that patient to optimize their outcome. So we often do prescribe the therapy, but again, we do that in collaboration with the therapists who have all the treatment protocols available. They used to be more nuanced. Now there's evidence to support some standard treatment protocols for those major reconstructive surgeries. And that's important to stay within the evidence again, as I've emphasized before.
Okay. Well, yeah, obviously we're here today, joining each other virtually. That's been a huge change over the last 2 years in all areas of care and society is the use of virtual communication, and also coming to terms with, communication and education and medical care, the limits of that use. I'm really curious. I know a lot of people right now watching are curious. What does that mean for physical therapy? What have we seen? What have we learned about virtual care in the realm of physical therapy over the last couple of years?
We've learned so much in the past 18 months or so with COVID, for sure. Physical therapy has successfully transitioned into that medium for appropriate conditions and people who have access to broadband. I guess first I wanted to just talk a little bit about what is telehealth or telerehab for physical therapists. And there are a lot of different things coming into the market right now. The first thing I'd like to say is the medium is what's changed for physical therapy. So when we talk about telerehab, it's a face-to-face interaction in an audio visual environment, much like we're talking now, where you're still working with a licensed physical therapist. Similar to the way you, obviously a little bit different, but same interaction you would have in a clinic. It's just in an audiovisual environment. That is different than some of the platforms or algorithms that have come out. They may very much be driven by physical therapist evidence or education or influence, but those are not what we would consider physical therapy. Some of the platforms do definitely improve access or act as a conduit to get people to care, but it is not what we would formally consider telerehab or telehealth. In terms of the efficacy, we learned a lot through COVID. One of the larger outcomes companies within physical therapy through COVID looked at this pretty in depth. And what they looked at was 3 different areas. So they looked at our outcome measures and functional status measures, and they found that telerehab and face-to-face had equally effective intervention strategies in terms of the functional outcomes. So they were equal. They also found that patient satisfaction was equal in a telerehab environment, as same as a face-to-face in-clinic environment. And then they also found early evidence that on average, a course of care was potentially 2 to 3 visits less, and that may suggest greater efficacy of care due to early access or improved access. So overall, COVID really showed us that when appropriately used for appropriate conditions, we do have good outcomes and it is effective. We do want to say that it's not a replacement for physical therapy care. It's an adjunct and again, needs to be used appropriately for appropriate diagnoses. And we are seeing that the best outcomes come when there's a hybrid of care. So maybe they are seen in the office for the evaluation, but then we use telerehab as an adjunct throughout their course of care. But we have seen patient preference in terms of them being able to either access the care earlier or in a regular, over a regular period of time. So less cancellations, less regular therapy. That's been a really big positive. We're also seeing that from the therapist point of view, we can see them in their natural environment, which is good for both of us. I had the opportunity to see patients doing their home exercise inappropriately or almost in a dangerous way at home, where it was a balanced patient that needed more external support to do that safely. Or I also got to see lots of throw rugs and small animals that could trip the patient. So lots of things that made us have a unique view into the patient's life, whether that be work, home, and where we could give more appropriate advice to help the patient in a larger way. But really, the big takeaway was that we can improve access through use when appropriate. And the other thing that in my 20-year career, I've never seen work at this level was the collaboration between payers and providers. It was really amazing to see how well those 2 groups were able to collaborate and figure out what are the different things we need to do to provide access in this, public health emergency. So this was just a really, obviously a silver lining of a pandemic that we were not prepared for in my mind. So all good things. And I think now I'm going to turn it over to Vycki to discuss some of the things that on the health plan side that are happening around the telehealth environment.
Thanks, Kelly. And I'll just echo your comments about the how accommodating health plans were. So as COVID-19 started and stay-at-home orders were occurring, many of our health plan partners did reach out to us and ask eviCore, what's our recommendation for the coverage of telehealth. And I think we all agreed that it was really important for patients to continue to receive therapy, not only to maintain their condition, but also to improve their condition or overall health. And if you think about it, asking someone who's vulnerable, like an elderly individual, to either go to therapy in person or to go without therapy was really placing them at risk. So, I think we were all happy to hear that the health plans were willing to change either their coverage policies or claims processing rules to accommodate telerehab in a home environment. Kelly or Elise, do you have additional stories that you'd like to share related to telerehab?
I mentioned a couple highlights. I wasn't sure how we were doing on time, so I'm happy to share some telehealth stories, or David, if we need to go on to the next topic, we can do that
I love your stories. Why don't you share one with us here, and then I'll move us forward.
Sounds good. So this is a patient we were seeing who was in her 80s, and I alluded to some of the things, but she really was lonely, so appreciated getting to see us, was immunocompromised, but we were able to see her for pain and a balance issue. And the thing that really came out of that was how she was doing her home exercise program with her little dog present, that was very much a fall hazard. We were able to assess her home environment and give her some things she needed to change just to prevent falls, especially while she was in pain. And then we were also able to, she gave us a tour of her home, and we were able to find key areas within her home that she could do her home exercises within her day. That also just helped with some of the outlook she was having being confined to her home. We were able to find places in her house where she could look outside and see the sun and just do different things that made her day a little bit more pleasant and change things, because she had been staying in one room the entire time. So it just allowed us to, one, give her something to look forward to, and we were able to incorporate her therapy into us seeing her home, teaching us about her hobbies and different things that I think made a big difference in her outlook over that month period. And she didn't fall, which after I saw her house was my primary concern.
Yeah, I never would have thought about patients not bringing those slippery rugs and rambunctious pets into the office. Something to worry about.
Right,
I
you
guess
just
it
don't
is.
see those things.
Yeah. So as we sort of hit the home stretch here, I do want to turn us toward the future. I have some questions I'll call out, and also just throw that over to the panelists here about what does the future of physical therapy hold. We've talked about some of that with direct access and virtual care, but curious about other ideas you have about the future and where we're going. Specifically, if you can weave these into your answers, we do have some questions about the relationship between surgeons and therapists, and should we require people to see a therapist before they go to a surgeon, or is that just is open access enough? Or what's the future of that relationship, and where people go first for pain? So if you could throw those into your answers, that'd be great.
Sure. So I think the big two things that I see is this PT first movement being a large one. And you touched on a point. I think the collaboration with our physician community is very important, because those red flags that Dr. Westergan talked about are really important, that hopefully we will be able to get to people faster. And sometimes we can also fast track them back to their physician, which is important sometimes, because we can write a report or get in touch with a physician or nurse practitioner and really put 2 or 3 concerning bullets together that the patient may not be able to articulate, and maybe even get them in faster. So I think the PT first point is a huge one that we see really changing conservative care management into the future, not only decreasing costs, but I've seen firsthand just the vast improvement in outcomes, return to work, return to life, and even moving them through the medical management pathway we have right now. Again, just because of the collaboration between physical therapists and the medical community, sometimes we can be more of a navigator to get them to where they need to be faster. The second thing is utilizing those digital mediums and telerehab to support access to PT, because we keep learning that we need to intervene earlier and we need more tools. There's only so many appointments. So being able to maybe screen someone in a digital format in a shorter appointment time, I think is going to be very important to getting them to the right provider, which may not be physical therapy. That first screen may directly, I've definitely sent someone directly to a physician from their PT appointment, and I know they got there faster because we were able to help make that connection. So I think the ability to work together as a medical community is going to be very important to coordinate care and get people to the right place quickly, because we know time is our enemy if we don't manage things appropriately. So those would be my 2 takeaways. And I think Elise has a couple things to add to that related to some pilots that we've done.
Sure. I'm just going to talk really quickly. I see we're out of time, David. Did you want to go on?
I could go on forever. Bill, I'll turn to Bill, who keeps me in control here. Do we still have time to pursue a few topics here?
I think so.
Good. I agree with you, Bill. I was hoping you wouldn't say anything. I was going to run over you, but go ahead. Tell us a little more, Elise.
Yeah, okay. What I'm going to do is just share really briefly that we're really looking forward as a profession for physical therapists to engage more with orthopedists as well as with health plans and employers on looking at value-based pilots. As you heard from today, we're talking about getting patients in earlier. We're talking about getting care that's managed via care pathways that are appropriate. And we feel that many of these things can be done via experimental pilots to start looking at the data and move this forward. And PTs are ready to do that. They're already collecting data and they're already adjusting practice models. I wanted to share some brief examples about what we're seeing in the PT community about innovative models that have been successful. First is a bundled care model in partnership with an ortho group. This started about 12 years ago. A national insurer had approached an ortho group in Wisconsin to set up a model to really differentiate that payer. So they started with bundles for total knee replacement and later added total hip replacement. The payer had initially planned to take this system-wide, but it was never pushed out. So the physician group had the initiative and they took it back to employers and said, you know, would you like to do this? The orthos then went into the community and start using specific criteria, assemble what they called their A team that included a Wisconsin physical therapist with multiple sites as the rehab arm. Employers were concerned about rising and disparate costs and varied regions, as well as the lack of consistency in quality and cost control. Currently, this ortho group and the PTs have 75 surgical diagnoses under the bundles. 200 employer groups have signed on to the models, many of which were self-funded. And employers are not directing care, but they facilitate direction through the lower out-of-pocket with the bundle. And the employers have the advantage of fixing costs and expecting good outcomes. The other model that I want to share real briefly is with an employer and a PT in partnership with a payer and a hospital. This is a corporate PT model, not really bundle payment. It's more of a population health approach. It's a joint effort in South Carolina with a hospital and the Blues for employers in collaboration with a physician group. The PT manages MSK as first-line provider. It began as a pilot by providing treatment for those without comorbidities, so without other special conditions. They did the analytics and asked if they would do direct access model for low back pain. The PTs were looking at this, and this is early on. Again, we're looking at a couple of years ago, and they thought it would be a cost-saving approach. The MSK costs were so high that the employer was really willing to do anything and do any novel approach that would change, you know, the current trajectory of cost. So the employer modified the benefit plan and encouraged access to PT. The MDs were open to the idea as well because the PCPs were very frustrated and didn't really feel that they knew how to direct low back pain patients. And the ortho really wanted to see more surgical cases. So in 1 year, the employer costs decreased 25% overall, with a 91% reduction in meds, including opioids. So again, going back to the impact of PT on reducing opioid addiction and opioid use. The approach saved approximately $1,500 per employee, and as a result, the program was expanded to other body areas, and in later years, the PT also shared the risk, so they now have a stake in the game. So thanks, David.
That's great. Keep the questions coming in, and we can answer some of them after the webinar as well and get back to you. I'll address some of them really quickly and throw a couple more out for comment. I do have some questions around chiropractic care and acupuncture care and other methods of conservative care and why they're not included today. And those are excellent questions. You know, we do support those delivery mechanisms of care as well. In fact, last October 24th was National Acupuncture and Oriental Medicine Awareness Day. We celebrated one of our employees, Shanta Van Lannen, who's a leading advocate for appropriate use of that form of care. And so we really are passionate about those as well. We're just focused on physical therapy today, but we're happy to talk more about chiropractic care and other forms of conservative care in the future as well. So I had a lot of questions around that and wanted to call that out. And we have some questions. I'm going to throw this over to you, Vicki. A few questions about authorization, and we've talked about open access and why is there still authorization, or what role is authorization still playing in this world today?
Sure, thanks. So I think where we're at is that unfortunately many therapists are doing the right thing and applying evidence-based practice, achieving the desired outcomes. But we find that there are still therapists who practice differently than their peers. And that's really why prior authorization exists, is it provides the opportunity to manage the therapy associated with a specific condition to better control cost and patient outcomes.
Okay, great. And I will just add that, we're not here to talk about eviCore or our solutions, but I will just say that we are, that's why we're here with the APTA. So we really want to advance the use of physical therapy, the excellent use of physical therapy, and we're big believers in value-based care as a way to progress forward and move from the sort of prior authorization model to a different model in the future as well. So that's something we're looking forward to in the future. So I see a few more questions coming in, but I think we'll call time now. We'll try to get those questions afterwards. Any final comments, Dr. Westergan, Vycki, Elise, Kelly, you want to make as we close out our session today?
Just to say thank you for everyone attending. We appreciate it, and we appreciate all the questions. So thank you.
Yes, thank you for the opportunity to be here. It was nice to talk with all of you today about a very important topic.
All right, thank you guys very much. I'll turn it back over to you, Bill. Wrap us up here.
Thank you again, David, and our clinical panelists for sharing your expert knowledge with us today. And thank you for all your attendance. This webinar was recorded and will be available on demand by visiting eviCore.com. Please remember to register for our upcoming webinars. You will receive an email invitation with the opportunity to do so. This concludes our webinar, and we hope you have a wonderful rest of the day.